these truths to be self-evident.
That all men are created equal.
As a member of Congress, I get to have a lot of really interesting people in the office. Experts on what they're talking about.
This is the podcast
for insights into the issues.
China, bioterrorism, Medicare for all. In-depth discussions.
Breaking it down into simple terms. We hold
these truths. We hold these truths.
With Dan Crenshaw.
The Eagle has landed.
Welcome back, folks. Another really interesting conversation upcoming here. And this one's about your health care. And look, it's dry. It's kind of hard to understand. A lot of people don't. People just want it fixed. People just want it to be cheaper. And getting to that point is incredibly complicated, and understanding the debate between Medicare for all and the more free market approach that Republicans have, and what that means for your health care, what that means for prices, and then everything in between that. It's complicated and worth unpacking. To help me do that, I have Lanhee Chen with me. And he's from the Hoover Institution, which, as you may know, is a conservative think tank at Stanford University. A very good one at that. And one I have visited and would like to visit again. So first of all, Lanhee, thanks so much for being on.
Thank you for having me. Appreciate it.
So you kind of know what you're talking about here. I'm going to read a little bit of your bio. You've been a longtime policy advisor, numerous presidential efforts, Romney-Ryan campaign, Marco Rubio's campaign. There was the Bush-Cheney re-election campaign, 2004 as well. You're a senior counselor at the Brunswick Group, a global business advisory firm. You do a whole number of things. There's really too many to note here, to be honest. What's your main? There's a lot here. Yeah. You're a very busy guy and very well qualified. What would you say your day-to-day is like now?
Yeah, well, I got a couple different things going on. I mean, I focused on healthcare issues and healthcare policy for the better part of the last 15 years, and have been through a lot of these fights, a lot of these debates we're going to talk about here on this show. I've been very engaged in trying to help conservatives and free market advocates come up with ideas on how we can make healthcare more affordable and more accessible, right? At the end of the day, that should be everyone's goal. And that's what I've been pretty focused on. So I've got, the fellowship at Hoover. I teach some at Stanford, do some business consulting and stuff on the side. So a lot of things going on, but healthcare is really at the middle of a lot of this stuff. It's fundamental to how people view a lot of different things. And if you don't have good healthcare, it's very hard to do a lot of other things. So it's a huge issue.
It is, and philosophically, it's worth accepting some of the premises from the left sometimes on this, which is we want people to have access to quality health care. Fair enough. You want to have universal health care. I can get behind that idea. Now the question becomes how you get to universal health care, and it's either government led or it's not, or it's a mix. And it's a complicated discussion. So, but let's bring it to the immediate term. We're debating a $3.5 trillion human infrastructure bill. It's the reconciliation package that we're calling it. There's about $1 trillion in new healthcare costs in that bill. A broad question is if we're spending $1 trillion new dollars on healthcare, and in this case, it's really to prop up the ACA, Obamacare, Medicaid, Medicare. Are we getting $1 trillion better when it comes to health in America?
No, we're not. I mean, I think we have to start, in my mind, back at the basics. And for me, the basic question is, how do you make healthcare more affordable, right? We all, I think, should share the goal of wanting more people to have access to affordable care. And if that care isn't affordable, if we don't have a system that's designed to ensure that we have a healthcare system that costs a reasonable amount of money, the conversation is almost worthless. You can throw tons of federal dollars at any given problem, and what you'll find is that you're really working on the margins. You're really working at a very incremental level. It's not going to be system changing. So basically, it's like you've got a car where the fundamentals of the car are broken in some ways, right? You've got the engine is busted. You've got some, really fundamental issue, and you're worried about tinting the windows, right? Mm-hmm. That's kind of the challenge we have. And by the way, you're taking it to a very expensive window tinter at that. That's the challenge we face, is that for the left, a lot of this is how much more money can we spend? The question I would rather ask is, how do we make healthcare better? How do we make it more affordable? And I wish there were more in this large infrastructure package to lower costs. That's not the focus of it, right? The focus of it is just how many more federal dollars can we throw out there to cover what is actually, in the grand scheme of things, a pretty small number of people. And that, in my mind, completely misses the conversation we should be having about healthcare.
Yeah, and look, primarily this is additional spending for Medicare. It would expand Medicare dental and vision, allow more people to sign up for Medicare. It would force what they call as a negotiation of drug prices. It is not actually that. We've gone over the HR 3 issue in the past on this podcast. But yeah. What's some of the truth on some of these expansion of benefits?
Yeah. Well, look, Medicare is a program that, by and large, people who are on it like it, and they like what Medicare is doing. We added a prescription drug benefit to Medicare back in 2003. That was much needed at the time. It's actually done a pretty good job, all things considered, in terms of making sure seniors have access to the medicines they need. Mm-hmm. But the Medicare program is out of date. I mean, you look at the program we have today, the program that was first designed in the 1960s, the realities of today are very different, and we need to modernize the program. So our focus really probably should be, first of all, on creating a program that makes more sense. And what I mean by that is, for example, giving seniors choices and options so they can get their Medicare benefits delivered through private plans if that's what they want. A lot of those private plans offer some of the benefits that the Democrats are proposing to add already. And so, again, I don't think anybody says, look, we want to give more seniors access to dental benefits. Absolutely we do. The question is, what's the right way to do it, right? Is it by throwing a lot more money into a government-run program, or trying to create a healthier marketplace, even within Medicare, so that people can have access to the benefits they want and need at a cost they can afford? The reason why a lot of private plans in Medicare already offer dental benefits is because people demanded that, and there was a need for that. And so what happens in a marketplace is, when you have a competitive marketplace and people are competing for business, they start to add benefits to make their plans more attractive. And that's what we've seen. It's a program called Medicare Advantage, right, that's been pretty successful. So my basic point is, I'm not against the idea of offering more benefits through Medicare. I just think we have to be smart about the way we do it. And the answer can't always be, let's just go spend a bunch more money to expand a program that may or may not be working. I think that's the challenge we have right now with what the Democrats are proposing.
So would it be, put simply, would you just suggest, obviously it's more complicated than this, but an expansion of Medicare Advantage particularly? Because other data that I saw when it comes to dental and vision, for instance, 95% of the people on Medicare Advantage already have these benefits, dental and vision. And maybe explain for the audience what exactly Medicare Advantage is, how it's different from normal Medicare, how many beneficiaries of Medicare are on Medicare Advantage, and just give us the summary of how that works.
So Medicare Advantage is actually technically a part of Medicare. So Medicare has different parts. There's a part that covers your hospitalization if you end up in the hospital. There's a part of it that covers what are called supplemental medical benefits, but that's really a fancy way of saying your doctor visits, right? Your non-hospital visits. There's a prescription drug component we've talked about. And then many years ago, Congress created what was originally called Part C of Medicare. For a while was called Medicare Plus Choice. And then in 2003, they changed the name to Medicare Advantage. And basically the concept is very simple, which is you have private plans providing the Medicare benefits, but doing it competitively with one another. And the plans themselves assume some of the risk around ensuring you stay healthy as a Medicare beneficiary. And so we have, in some parts of the country, upwards of 60-70% of seniors on Medicare Advantage plans. In other parts of the country, it's lower. It really depends on what state you're in and how competitive of a marketplace there are. But my point about these Medicare Advantage plans is that often what happens is that seniors like the idea of being on these plans because they provide access not just to the traditional Medicare benefits, but these plans have added benefits, right? They'll say, for example, hey, we're also going to provide you dental and vision at no added cost. We're going to provide you a lower rate, for example, if you're a membership of a health gym, if you work out or if you try to tend to your health or you walk on a regular basis, maybe your costs will be lower. So there's been some creativity in this program, which, because it's fundamentally a government-run program, for many years there hasn't been that creativity allowed. Medicare Advantage has really allowed some of that creativity to take off. And so what Medicare Advantage basically is, at the end of the day, is it's a way for seniors to get their Medicare benefits, but to do it in a way that looks more like how non-seniors get their benefits, through private plans, right? Workplace-based private plans they're buying on their own. So it's really trying to take a program that was designed in the 1960s and modernizing it for 2021. And that's, I think, why Medicare Advantage plans have been pretty popular with a lot of seniors in some states.
And how does that work for the senior? So they're eligible for Medicare, and they want to sign up for Medicare Advantage. Do they just choose a plan? But if they want, maybe they want a plan that offers more benefits, they can choose to pay more on top of that. So
they'll pay a little more.
Yeah, so they're basically they're subsidized by the Medicare program to buy those in private insurance plans.
Yeah, So basically, there's a certain amount of money that Medicare kicks in, right? Because you'd be getting your benefits before Medicare Advantage. Everybody got their benefits through a program, through the Medicare program, in a system that we call fee-for-service. Mm-hmm. That's a very fancy way of saying when you show up at a doctor's office for a particular treatment or a particular condition, the physician and the providers get compensated per service they provide, fee-for-service. What Medicare Advantage tries to do is to basically package things together and say, we're going to try, to the extent we can, to take care of you holistically rather than paying for things one by one, right? And that concept is really why Medicare Advantage plans in a lot of ways are able to be more efficient than traditional Medicare. And so what happens at the end of the day is, look, you as a Medicare beneficiary, the government's going to pay a certain amount for your coverage, just as they would if you got your coverage fee-for-service. If you get it in Medicare Advantage, they're going to pay a certain amount toward that. And if you want more benefits or you want a different kind of plan, you're going to pay a little bit more. Very similar to the way we do things in commercial health insurance and regular health insurance for people who are not yet 65.
Yeah, and the reason I ask about subsidizing the patient so that they can make choices, that's kind of important for what I want to get to a little bit later about how we might look at the individual market outside of the Medicare issue. But so just plug in that for the audience. But I want to continue on this conversation on the solvency of Medicare. How is it paid for? Let's educate the public on this. So it's paid. Well, I'm just going to tell everybody it's paid for through your payroll taxes. Much like your Social Security is paid for. A portion of that goes into the Medicare Trust Fund, which is why it's viewed as this entitlement. People feel as though they've paid into it, and therefore they've earned it. And I think that's partly true. I think in the end, though, this was just, you talk about an old program. It was designed for a population that was not living nearly as long as we're living now. So I think most people, it would seem, tend to get a lot more bang for their buck. And that seems great, except that it also makes the program completely insolvent because we're living longer, which is great. But it also means that we need to reform these programs. So maybe talk to us about the financing for a little bit.
Yeah. So you've outlined it very well. Basically, as I noted earlier, there are many parts to Medicare. The part that covers inpatient hospitalization, Part A, is financed by what's called the Hospital Insurance Trust Fund. And that trust fund is paid for by your taxes, by your payroll taxes. Out of every check when you're working, you will see a deduction for Social Security and a deduction for Medicare. What's the problem? Well, the problem is more people are on Medicare because we have a demographic shift going on in America, where more and more people the baby boomers are coming onto the Medicare program, and they're being supported by fewer and fewer workers because That's just the reality of our demographics in this country. By the way, the other problem we have there is that not only are there fewer workers supporting more people going on Medicare, but healthcare is getting more expensive every year. So you have two problems. You have a demographic challenge, but you also have this cost challenge because healthcare is getting ever more expensive and more people are on the program. You can quickly see what the problem is with the trust fund. You've got the trust fund is being drawn down more quickly. And the challenge is when that trust fund is exhausted, in other words, when the money in that trust fund is done and we start going negative, Medicare benefits have to get cut. That's what the law says, actually. And you can't choose, by the way, whose benefits get cut. Everyone's benefits have to get cut. Same thing happens with Social Security. So when people on the progressive left kind of basically say we don't have to worry about the trust funds, I couldn't disagree more with that. We do have to worry about the trust funds. We have to worry about their solvency because those are tied to the ability of Medicare to pay benefits. And if we're not paying those benefits, people aren't getting access to health care. So the financing of that part of Medicare is very precarious. There also, as I mentioned, Part B. Part B is essentially medical visits, doctor's office visits. Those are funded by premiums people pay. And the same thing goes, by the way, for prescription drug benefits, Part D. Those are also financed by premiums. So the trust fund that we're talking about is specifically related to the inpatient hospitalization piece.
Yeah, which is often the most expensive, especially
for
the
elderly. Question. Yeah.
It's okay. So how does that financing get affected if we add $1 trillion of spending to these programs, which is really financed from the general fund because it would be passed in this reconciliation package? How does that affect the overall solvency of it? Because it's not changing the structure. You know, what's your take on that?
Well, it comes back to the overall problem we have, which is that some people think we can print as much money as we want to. And, you know, the reality is that's going to cause all sorts of problems. When you start printing too much money, the money becomes relatively more worthless. It's a process of inflation that we have that we're already seeing in our economy now because we've gone through a period of massive fiscal expansion. A lot of spending has already been approved. Some of it because of the pandemic and coming out of that, but some of it is just, you know, we've forgotten how much $1 trillion is really worth, honestly. And so the challenge becomes the more fiscal expansion you have, the fewer dollars there are going to be to pay for the things you really need to pay for, like healthcare. Another way to look at it is at some point, we're going to have to increase the amount of money we have coming in unless we want to borrow indefinitely, which creates all sorts of challenges that we don't want, right? We don't want to be borrowing more money from countries like China, who we fundamentally can't trust. And so when you have a fiscal expansion, it puts pressure on programs like Medicare because the dollars, there's only so many of them to go around. And at some point, if you need to bail out the Medicare trust fund, where's that money going to come from? That's the basic point. That's why, you know, Democrats say, well, none of the spending is going to affect the trust fund. And they're technically right, but that misses the bigger point, which is that if you got dollars sloshing around everywhere, at some point, you're going to have to figure out how you pay for this stuff. And then it becomes a question of priorities, right? And Medicare is just going to be one of those priorities. If you're going to bail out Medicare because the trust fund's out of money, but she's committed to spend money on something else, that's where the problem comes in.
Yeah, and it's that gets to a larger discussion of debt, and the issue with that is, you know, we don't know when it's going to hit us across the head. It's right. No economist does. Right. Like, when is there too much debt? When is it completely unsustainable? But back to the Medicare solvency, the other issue is too, you're expanding benefits. You're expanding benefits, and you're saying, okay, we're going to pay for that expansion out of the. And correct me if I'm getting this kind of wrong because it's confusing. You're expanding those benefits funded out of the general fund, which means we're just borrowing the money. And but the thing is those are expanded benefits that will never go away. The money we're allocating to this is part of a 10-year budget, but those benefits never go away. So Does it move up the estimated date of Medicare insolvency from the trust fund specifically?
So this is part of the argument Democrats make is they say, well, listen, we're adding these benefits, but because they're outpatient benefits, they don't affect the trust fund. Remember, we talked about the trust fund being just for hospitalization. So technically, they're not wrong about that, right? Because the hospitalization piece, the trust fund piece is separate. The trust fund, as we've talked about already, has its own problems. It's a question of how quickly that trust fund gets exhausted. It's not if, it's when. The separate problem that we're talking about now is when you're borrowing money to pay out of the general fund for additional benefits, and those benefits never go away, you have just committed yourself to spending an indefinite amount of money over not just the next 10 years, but into perpetuity, basically. So it feeds into the debt question in my mind, which is, how are you going to pay for all these benefits? You're not going to pay for it out of the trust fund. That's true. The trust fund is for hospitalization, but that trust fund has its own problems. Now you've created a second problem, which is how you're going to pay for all these extra benefits you've just added. And in my mind, that is a challenge that nobody has answered the question. I mean, nobody has said, how are you going to pay for this stuff? Mm-hmm. They don't have an answer for it, right? Because their answer is, well, we'll just raise taxes and borrow more money. And that's always the answer for these new benefits.
Works out great. One of the things they like to say too, I mean, if it's not Medicare for all, it's what mainstream Democrats can get behind is, lowering the age, the eligibility age for Medicare. They want to lower it to 60 or 55, whatever. And again, it's a popular program. So people are like, well, that seems fine, right? That seems like a reasonable compromise. Now, I'm not sure it's a reasonable compromise because I thought we should be increasing the age, not decreasing it. If the entire point is to keep senior citizens out of poverty, I would think that, given that our life expectancy has gone up dramatically since these programs were instituted, you would think we'd be raising it, not lowering it. Same for Social Security. The other thing that strikes me is interesting. I think you wrote about this. You write about everything, so I'm sure you wrote about this. If we lowered the age to 60, I mean, who are we helping? And it turns out a very low percentage of that population is uninsured. The other thing as a millennial that really gets to me is when we talk about these benefits is it's so clearly a transfer of wealth from the poor to the rich. Because what's the number one indicator of wealth in this country, in any country? It's your age. I mean, if you know nothing about a person and you want to know one defining factor about them and you know their age, well, then, and if you guess that the older person is wealthier than the younger person, you're normally going to be right. And so it doesn't make sense to me that we'd be giving that particular population more benefits. And again, make it really harming our solvency issue. So that mere action would dramatically change our solvency issue. And then the question is, how do you pay for that?
Yeah. Look, I'm for solving the problem, right? If you said to me, okay, look, if we lower the eligibility age now and say anybody who's 60 instead of 65 can get into Medicare, and we're going to be helping 30 million people, I'd say, well, let's have that conversation. That's not what's happening here. We're talking about spending a massive amount of money, expanding an entitlement program into perpetuity, by the way, crowding out coverage that's being provided already in the private sector in many cases, shifting people from private coverage to government coverage, and adding costs for people in your generation and mine to help 3.5 million people, basically. Yeah. And is there another way to help those 3.5 million people? Absolutely there is. Let's figure out how to create competitive markets that lower the cost of healthcare, expand the availability of benefits. That's what we should be doing, not expanding a government program to cover a few more people that's going to end up costing billions upon billions of dollars in the long run. That's my issue with lowering the eligibility ages. Again, it's the bazooka to kill an ant philosophy. Mm-hmm. We should be figuring out how to target benefits. And by the way, a lot of people have advocated for these approaches. Basically, let's help states expand coverage to more people. Let's give them more flexibility, because the situation you face in Texas is different than where I am in California. in terms of the kinds of people who need help, the nature of that help, who is it that's uninsured. We need to be much more targeted in our approach, as opposed to saying, well, let's just expand the government program and we'll figure it out later. That to me is totally the wrong approach.
Let's move on to your opinions on the Affordable Care Act, Obamacare. Just maybe summarize for the audience what exactly it is, what exactly it changed. I'm not even sure a lot of people really have a good grasp of how to describe that, and what it really did to the market as a result.
Yeah. Well, look, there's 2,000 pages in the law, so it could take us, 2,000 hours to figure out what's in it. I'll try and summarize it quickly. Basically, what Obamacare did was it tried to figure out how to make health insurance from one person to another look more similar. All right. So before Obamacare, we had a lot of different kinds of health insurance, a lot of different kinds of benefits. You could show up and say, hey, I'm young and relatively healthy. I kind of want to buy a cheaper insurance plan. And, if I go snowboarding and I break my arm, then there'll be coverage for that. But otherwise, the kind of what we might consider more nickel and dime stuff, the plan wouldn't cover it. Someone else might say, hey, look, I want to buy the Cadillac plan of Cadillac plans. I want to buy the plan that will cover everything from the first dollar. And you had that choice. Obamacare took that choice away and basically said, everybody's got to have health insurance that has essentially the same suite of benefits. And everybody's got to get charged the same amount, with the exception of your age, your gender, and whether you smoke or not. So it standardized the health insurance marketplace and limited the amount of competition in the marketplace. So that's the first thing that it did. The second thing that it did is it basically created a set of rules around what health insurers could and couldn't do. And that's related to the first point I made. So for example, health insurers couldn't kick you off coverage. If you had a pre-existing condition, they had to offer you coverage. Some of that stuff is very popular and for good reason. And those rules work along with the rules I discussed earlier to basically transform the marketplace for health insurance. The bigger part of what Obamacare did is just to expand government coverage. The single biggest source of new people getting health insurance through Obamacare was through the expansion of a program called Medicaid, not Medicare, Medicaid, which is a program that is run jointly by the federal government and states and was originally created to help low-income single moms. When the program was first created, it was low-income single moms, then it was low-income single moms and their kids, then it was just low-income folks who were, had particular conditions or situations. Then Obamacare came along and said, we're going to open up Medicaid for anybody making less than 138% of the federal poverty line. And that was, as it turns out, millions upon millions upon millions of people getting into government coverage. When Obamacare was first passed, by the way, they said every state, remember I said it was jointly run by the feds and the states, they said every state has to expand Medicaid. There was a Supreme Court case that came along where the Supreme Court said, not so fast. You can't actually make states do that, okay? So states have to have an option on whether they want to expand Medicaid or not. So some states did, some states didn't. But basically, the core of Obamacare really comes down to that. A lot more people in government coverage, a lot more regulation at the federal level, and fewer choices in the marketplace. Were there some things it did, again, that people like? Absolutely. Is Obamacare ever going to get repealed? Probably not. Not where we sit today. It's just been too long. The program's been in effect for over 10 years. Can we change it to make it work better and to improve, the cost situation and the access situation? Can we renovate it? Can we figure out how to make the law actually work? Sure we can. But the point is, the core of Obamacare, the essence of Obamacare really was, how can we get the federal government more involved in healthcare?
Yeah.
That's basically it.
And it also caused premiums to rise. I mean, the promise was that prices would drop as a result of Obamacare. That promise was not realized. We've seen consistent rises in premiums. What's fundamentally what causes that?
Well, yeah. I mean, the reason why is again, there's two explanations. One is healthcare is becoming more expensive, so the input costs are rising. But really, the bigger issue here is the reason why health insurance premiums on the Obamacare marketplaces specifically, Obamacare created these marketplaces where people who didn't have job-based insurance could go buy their coverage. Those costs have skyrocketed. Now, why have they skyrocketed? Because there's no choice of plans anymore, right? You've basically said we got to have the same kind of coverage, and we're going to dictate how much these things are going to cost. So what you're doing is, let's just be very clear about this. You are increasing costs for people who are broadly healthier and broadly younger to pay for people who are broadly sicker and broadly older. Now, as society, we make decisions all the time to help people who are sicker and who are older to get coverage. I don't oppose that idea. The problem is that Obamacare is not transparent about it. It basically says everybody's got to pay more, and we got to pay more just because. Let's be clear about why we're paying more. We're paying more because we basically said every single plan's got to look the same, and it's got to have all these benefits. By the way, what Obamacare said is you can't buy a plan without coverage for pregnancy. Now, I'm all for that when you're talking about people who can actually get pregnant. But does it make sense to add prenatal coverage, all these other mandates to plans for people who don't need them? My point is, let's give a broader variety of choices and let people choose the coverage they want that suits them where they are in their lives, and let's price it accordingly. So it's just a different philosophy, right? Obamacare is basically saying everything's going to be the same, and because everything's the same, the costs have gone up.
Yeah, when Democrats, let's call them more supposedly moderate Democrats, say they're not for Medicare for all. They're just for all of these other programs, whether it's the ACA or whether it's lowering the eligibility age for Medicare. They're for all of these other options that put you on an inevitable path to where everyone is covered by either Medicaid or Medicare, which kind of just looks like Medicare for all. So whether you're in either program.
Some people talk. There's been talk about the so-called public option. Same problem, right? It's basically saying we want government to get in the business of competing against private plans. And what's going to happen? If you subsidize something with taxpayer money, of course it's going to be cheaper, right? So then what's going to happen is more and more people get into government coverage. Then they're already in government coverage. It's a hop, skip, and a jump to Medicare for all from there. So all of these things are like gateway drugs for more federal involvement in the healthcare system. And I think that's the challenge.
Okay, but what's wrong with Medicare for all, they say? What's wrong with me just going to a doctor and not worrying about the bill because they're just going to bill the government? Because that seems kind of nice.
It does seem kind of nice. It's very seductive, actually. And they point to other countries that have single-payer systems, and they say, hey, people seem perfectly fine in the UK and Canada and in countries around the world. There's a number of problems. First of all, fiscally, it ends up being unsustainable, right? At some point, because of healthcare costs going up and more people in government coverage, it becomes so expensive that eventually the taxpayers got to pay for it. And by the way, not just rich people, because that's the other thing that is used as a seductive part of this argument is progressives will say, oh, it's very easy. You just tax the rich. There are not enough rich people, and there's not enough money there to pay for all the benefits they contemplate under Medicare for all. It is at some point going to mean that even middle-income taxpayers, even lower middle-income taxpayers are going to have to pay more. We've done the research. We've shown that this is the case, right? Yeah. So that's the problem with it, number one. Number two is you think there's really great innovation in healthcare in countries that have single-payer systems? No. There's not. The reason the American healthcare system is creative and innovative and on the cutting edge is because we have a market-based system. That's fundamental to why we have such an advanced healthcare system. Doesn't mean that the care in Canada or the UK is necessarily bad. It just means they don't have innovation. The other thing that they have that we don't have here is rationing. They have the government because, again, if everybody gets their benefits through the government, it's up to the government to decide who gets the benefits and who doesn't. So what you have in the UK, for example, is if you want to get an advanced procedure done, you got to wait in line, or the government will say to you, you know what, you don't need that procedure yet. And that's, I think, the most fatal flaw of the single payer movement is this reality of direct rationing of care by the government in every single country that has a single payer system. Bar none, that is what happens. And so, it sounds great until you actually start to dig into it and realize what the implications of it are.
Yeah, I mean, there's policymaking is about trade-offs, and people from Canada come to the U.S. because they can't get major procedures done. Now, look, and they'll say Americans go to Canada because they can't get drugs at a reasonable price. That's also true. So, but I'd rather be in our situation where we're basically going on a healthcare tourism for the sake of lowering a price, as opposed to healthcare tourism because my life depends on it. Because I just can't get into that MRI scan. I mean, the wait times are pretty significant, and it's worth explaining to people, why do wait times increase? Well, it's because you have less doctors, you have less facilities. Why do you have less of these things? Well, because you're underpaying them. Because Medicare for All, I think, put simply, is just a series of price controls. Because now we control the entire market, the government being we, and it's going to be a lower reimbursement rate than, say, a private insurance would pay. One thing I want to ask you generally too is you say, look, one of the reasons these things aren't working as well is because the price of healthcare generally just keeps increasing. I think people have trouble understanding why that might be, and the answer is, of course, complicated. A lot of factors involved, but maybe you could put it simply for us. I mean, are we getting more for at least a lot of those price increases, or are we not? I think that's debatable as well.
Yeah, well, I think the answer is sometimes we are. So part of the reason it's becoming more expensive is because technology is getting better. And with technology and innovation comes invariably more cost. Now, I think the bigger challenge we have in our healthcare system, though, is this. I think this is why we're seeing costs go up as they are, which is that we don't actually have a great sense for what we're paying for. We don't have a lot of transparency into what things cost and what the benefits are. And by the way, the quality of care, a lot of times we don't know what we're paying for. You think about any marketplace, right? If you didn't have information about how good a particular TV was compared to another, or how good a particular sandwich was compared to another, they could charge whatever they want for it, right? And I think that's what we have in our healthcare system, is we don't have a great sense for what we're actually paying for. And some of that is built into our system, because we have this system where we, as the end consumers of healthcare, don't actually know how much it costs, because there's insurance. The insurers are negotiating prices with the providers. There's all these intermediaries who, and it's not necessarily bad. My point is, if everybody provided more transparency along the way, and we had more control over the money we're spending, then we would have perhaps a better pathway to lowering the cost of healthcare, because you could have a competitive marketplace. This is why, for example, I'm a big believer in health savings accounts, which are basically accounts that you keep and you save your own money for healthcare benefits, and that money grows tax-free. And you could use that effectively. We're not using them as effectively as we can now, because you don't actually have any way of comparing between different providers and prices and quality. And so you are still spending somewhat blindly. So over the last couple of years, there have been efforts to enhance transparency, to make sure people understand a little bit better what their money is going toward. Those are very, very important developments in our healthcare system. And until and unless we get there, it's going to be very hard to control costs.
Yeah, so it's a combination of a lack of choice and competition. There's the great myth that we're in a free market healthcare system. We are very clearly not. It's maybe more so than other countries, but because at least there's profits involved. But in a free market, the way we might think about other industries. And second of all, there's just better stuff. I mean, which makes it more expensive. Yeah. I mean, which isn't a bad thing. We do get more for our healthcare than other countries do, or more for the price we're paying than other countries do. We have to admit that. We have access to far more new cutting edge drugs than all of our other developed nations as well. So people don't quite realize that. You mentioned health savings accounts, so that's a good way to end the discussion, because we got to tell people what we're for. Republicans have done a really bad job of this generally, providing just a vision of like maybe not what next bill we want to pass, but because I think it should be incrementally done. Like you said, you're not going to just repeal Obamacare. What does that even mean at this point? You've got to change. You got to change the system from within and change it slowly because it freaks people out when you start changing it radically about healthcare. And I think they made that pretty clear back in the. I wasn't around, thank God, during those debates for the repeal and replace debates. People were really pissed off. I mean, they might not like Obamacare, but they're not sure why they don't like it. But they also don't want massive change. Okay, so what's our vision? And it kind of seems to me, because we talked about this with reforming Medicare, for instance, it's make it more like Medicare Advantage. Well, Medicare Advantage fundamentally is that you're subsidizing a patient, you're empowering a patient to make choices on the market. So the safety net's still there, which is the whole point, right? That's the crux of the debate. Should there be a safety net? And we could all agree there should be. Safety net's there, but you also get that choice and competition along with it, and which maintains the level of quality that we don't want to lose, which we would lose with Medicare for all. And so it seems to me like empowering the patient through health savings accounts in a sort of Medicare Advantage kind of way. Maybe it's Medicare Advantage for all is really what we're looking for. Where not everybody's necessarily eligible for these subsidies, but the people who truly need it might be. And that could, and then at that point, if that's the case, then why do you need Medicaid even? Are you even spending more money if you start to design a vision that way and try to get there eventually? I mean, what do you think of that general pitch?
Yeah, well, look, I come back to a couple of core principles when I think about how to improve our healthcare system. By the way, my colleagues and I at the Hoover Institution, we are developing now a comprehensive set of proposals that we can be for. If we want better choice, better competition, lower costs, more functioning markets, we do need ideas. And so we're going to put that out next year, hopefully, and get it into the bloodstream. Look, I think there's a few things we got to do, right? One is we do have to empower the individual with information and choice and competition. We need better information, and then we got to do our best to help people make smart decisions. We've got to make sure that people can save and invest for their health care. We've got to make sure that we bring the cost down and make it more affordable, again, through a healthier marketplace with more choice and competition. We need to address constraints at the state level as well, which is why I'm such a big fan of the federal government really giving states more freedom and flexibility. All these decisions shouldn't be made in Washington. They really shouldn't. Because if you think about healthcare, there's no national marketplace for healthcare. It's all local. So why are you regulating at the federal level for something that's so local? So let's turn over to states more freedom and flexibility to use money to target the uninsured, to get costs down. Let's give states incentives to create more supply of healthcare too, right? There's some places where we're seeing that costs are rising because of litigation, healthcare litigation, right? Doctors are afraid of being sued, and so they're practicing defensive medicine and their costs are going up. We're seeing some places where we're not letting nurses practice to the top of their licenses. That shouldn't be the case. We need more supply, not less. So these are the kinds of things that can happen at the state level if the federal government just says, you guys take the wheel. We're going to give you maybe some guardrails, but you go and you drive. The combination of these policies I've just mentioned can do a lot, not just to lower the cost of healthcare, but as a result, make sure more Americans get access to quality coverage. And that's what we want. We should be a party in a movement that says, yes, we want more people to have health insurance. We want it to be better health insurance. And we want that health insurance not just to be better and more accessible, but also to have a better cost profile in the long run. And we can do those things, but we've got to start being in the ideas business again. So I'm actually very optimistic. Folks like you and others in the Congress who are going to be able to hopefully start to set us on the right path when it comes to these things, because for the last 10 years, I just think we've gotten way too deep. The federal government's gotten way too deep in the healthcare system. And that, to me, is a recipe for unsustainability.
And I think we all being conservatives generally, we agree with all of the policy measures that you just stated. They would create a better system overall, and that should be a number one priority. It's hard to tinker with the system if you don't if you don't deal with the foundational problems of it. And everything you just mentioned does that. But if I'm a liberal, I'm going to have the question, what about the people who are still too poor to pay for any premiums at all? What do you do with them? So you keep expanding Medicaid because like 130, what was it? ACA makes you
138,
eligible for, 138% of the poverty line. That still ain't a lot of money. So, there's this sort of working poor class that is in America. Yeah. And we have to acknowledge that as conservatives, which is kind of what brings me back. Okay, what do we do about them? Because it's that individual market, right? They don't have employer health plans. They're too rich for Medicaid, and Medicaid's a crappy program anyway. So maybe the people who are the working poor and the people in Medicaid, how can we better meet their needs? And it gets me back to the sort of the Medicare Advantage design, right? It's what if they all had a health savings account and the government just injected, depending on their income level, depending on their situation, it's means tested. You inject money into that health savings account, and with that they can purchase their direct primary care. I'm a big fan of direct primary care. Yeah. Which basically it's like a subscription service to a primary care doctor. We've talked about it a lot on this podcast, I think. But in addition to that, you can pay for your insurance as well. So you're now in the driver's seat there. Insurance companies have to compete for you. Maybe there's a single point of a single website where you can actually more clearly shop for insurance, but it just kind of exists right now in the ACA in a way. So I don't know. This is that's because that's the subject matter that people are still concerned about, that Republicans haven't really answered.
Yeah, well, we have to be focused on the working poor. There's no question about it. And what if we had a platform, to your point, where you got a lot of different plans competing for their business, and you have the federal government kicking in some amount of money. By the way, state governments also can kick in as well to help make it more affordable. You create a platform where they can have access to an affordable plan, a choice of different plans, right? So it's not just a single plan like Medicaid. Here's a bunch of different plans you can choose from. And you are on the same marketplace as everybody else. One of the things we have in this country, we have way too much of, is we want to stick people into programs, right? Mm-hmm. Why not just say, hey, look, we got a great marketplace that we've got up and running and working well. I don't care if you're making 125% of poverty or 500% of poverty. You're going to be in the same marketplace, and you get the exact same plan. You don't get a plan that's earmarked for people on Medicaid. No, you get the same plan, the same benefits, the same coverage as someone who's wealthier. But we're going to give you a little bit more support because we know that you need a little more support to make it. And we should be willing to do that, by the way. We shouldn't be stingy about those things, right? I mean, if people need help, they've come on tough times, they're working their way up, they're trying to get to that next job that's going to pay them a little bit more to support their family, we should be in a position to help them. And we can be.
Yeah, and I think that it also intuitively makes sense to people. It's also very consistent with conservative principles. It's how we see the housing market too. It's like, do we want to stick people in this sort of Section 8 program? Why not just give them a little bit of help with their rent, and put them in the same marketplace as everyone else instead of stigmatizing people in the way that we do, and we might be on a better path. And it seems to me that it's difficult to get there. It seems to me that this would require some incremental implementation over many years, so not to scare everybody off. But I think it's important for Republicans to actually provide a vision, our idealist vision that we can describe to people in an elevator pitch. Because right now the Democrats own that market really well. Medicare for all is very, very simple to understand, and it's a bit harder to explain our position. But I think we've done a pretty good job on this podcast. I think we solved the world's problems.
No question. We got there.
we did it.
We got there.
It's been almost an hour. Lanhee, thanks so much for being on. That was very informative.
Thank you.
And for those who stuck through it, they're much better postured to deal with the healthcare debate. So thank you.
Thank you.
Where can people follow you? Website or Twitter or whatever it is?
Yeah, so my Twitter is just at Lanhee Chen, LANHEECHEN.
Gotcha. Awesome. Lanhee, thanks for your expertise on this. Appreciate it.
Great to be with you.